thank you. And thanks, Jawad, for letting me speak. I'm a consultant anaesthetist, and as all good anaesthetists, I'll be quick. As Tim alluded, I work at the Surrey Count Hospital down in Guildford. We're a district general hospital. We do provide secondary care for a lot of specialties, but we're also a tertiary cancer centre. And we provide surgical care for things like HPB, which is why I'm here, but OG, MaxVac, ENT, and gynecology. And we're also a centre of excellence for enhanced recovery. And enhanced recovery, as Tim said, is very much embedded into the Royal Surrey. I want to go and just show you a little bit of data. This is from the GIRF data from last month, and this is a number of elective liver resection procedures for cancer, and we are that black bar just there. So we are consistently a high-volume liver resection centre. And I want to get back to open liver resections, which is, remember we do open as well as robotic. But we developed an enhanced recovery pathway for open liver resections, and it was all published in the BJS back in 2013. And it's an enhanced recovery pathway, so it's a standardised pathway that all patients get. From the anaesthetic side, they get an arterial line, they get a CVC line, and they have a thoracic epidural. And we run a low CVP technique, so we give them frusemide, we give them a GTN infusion, and we do not give them any fluid intraoperatively until the resection is completed. All patients go to the intensive care unit post-operatively. And that has meant that we have the lowest length of stay for all our open liver resections in the UK, and that's 4 days. But then changes started to occur. So we started to get more HPB surgeons, and with the arrival of those surgeons, there was a steady increase of laparoscopic liver resections. With the enhanced recovery protocol, we were giving patients preload at midnight and then around 6 o'clock in the morning. But we started to put in sip and send. So patients would sip water until we sent for them, which was pretty novel. But with those laparoscopic liver resections, we were still sending them to intensive care because they were still having a liver resection. And the Southampton risk score, they started doing that. And I'll touch on that in a second. But first, I just want to talk about what they teach you in the first few days of anaesthesia school. They teach you how to do the crossword, both normal and cryptic. They teach you how to adjust the table and move the lights. But they also teach you never trust a surgeon. And the Southampton risk score was a prime example. So as you know, this score helps to predict the likelihood of conversion to open surgery, and you'd stratify them to low, moderate, high, or extremely high. And what we were doing was we were doing the Southampton risk score, and our anaesthetic was really based on this, plus open liver resections. We were still pretty new to how this would really work. And remember, never trust a surgeon. So they say it's a very low risk of conversion. Yeah, right. We'll stick all our lines in, don't you worry. And so we would still run a low CVP technique, valiantly trying to drop that CVP despite the pneumoperitoneum. We would run them dry, and the patients were still going to intensive care. And so when we actually started to look at the data, as Tim said, our length of stay didn't correlate with the Southampton risk score, but it actually correlated with the intensive care length of stay. So we were easily getting patients in, but we couldn't get them out again. There was no flow out into the ward. And then this thing arrived. So they started doing this, and the banter in theatre really dropped down after that. So what's the future? Well, we are still in transition, but we are developing and finalising the enhanced recovery pathway on minimally invasive liver resection. We are still carrying out the risk score, but actually we're starting to trust the surgeons a little bit more, and we have a discussion with them, and actually that supersedes the Southampton risk score. We do still consent patients for all the lines if the risk of conversion is high or extremely high. The moderates are the tricky ones. And we're still continuing to do sip and send, which actually the patients really like. The experience of the patients who can drink when they're sort of second or third on the list is amazing, and they don't They don't get any nausea and vomiting. They get out of recovery very quickly. We don't put thoracic epidurals into the minimally invasive liver resections. We were putting in spinals for those who are high risk or extremely high risk of conversion. We're now sort of going away from that as well. We've got a very established robotic urology service, and they've moved away completely from spinals and using things like ketamine, which is working really well. But controversially, slightly, we're not sending them to intensive care because actually we're showing that they don't need it and they can have a timely discharge. So, in essence, the anaesthesia side of things, we're working very closely with the surgeons, but together we're developing this enhanced recovery pathway, which means that we can send the patients home much quicker with a better experience. And as you've heard with the health economics and the SF36, they can have a better experience and a better quality of life. Thank you.